Hello, I am Jesus Bañales, Professor of Molecular Biology in San Sebastian, Spain, and I am very pleased to introduce and give you an update of the World Cholangiocarcinoma Registry. I am so sorry, it's a pity that I cannot be in person this year at the MMF meeting, but I send you very warm regards and all the best for the meeting, and I am looking forward to see all of you next year in London. So, as an introduction, the World Cholangiocarcinoma Registry is an observational study, retrospective and prospective data capture from 2016. We have different sponsors and partners. So we obtain competitive funds from the ESCAA, from the European Association for the Study of the Liver, with the registry grant awards in 2016, 19, and 2022. From ENSCAA in 2020 and also this year in 2023, as well as from the European Commission. We have different partners, the Spanish Association of Gastroenterology, the patient associations, the EMMF, the Cholangiocarcinoma Foundation, the Global Cholangiocarcinoma Alliance, as well as the scientific groups, International PSC Study Group, and the European Referent Networks, EuroCan and ERN Rare Liver. This includes a systematic capture of covariates included in the RepCap online platform. So we are including clinical information, general data on demographics, risk factors, and medical history, clinical parameters, biochemical and immunological. Cholangiocarcinoma features a diagnosis, presentation, staging, treatments, molecular profiling, and also the presence of other kind of tumors. And also we include information on the availability of biological samples in order to participate in collaborative studies. So in general, we are able to include up to 300 different data fields. So this is an excellent online platform for collaborative research projects. So the main objective of the registry is to determine and monitor the presentation and management of patients with cholangiocarcinoma to improve the diagnosis, classification, treatment, and prognosis of patients with cholangiocarcinoma. We want to broaden the current cholangiocarcinoma classification by introducing information on morphological, immunohistochemical, genetic, and molecular parameters to elucidate the cargo of environmental factors in the development and progression of cholangiocarcinoma, to identify novel cholangiocarcinoma biomarkers for early diagnosis and screening, and to estimate prognosis and response to therapies, to compare the effectiveness of the different therapies, and to select patients for clinical trials. So I am the promoter and coordinator of the registry. Laura Izquierdo is the registry manager who is doing an extraordinary work in the registry and a lot of work and effort. We have a person dedicated and who is supporting us on legal and regulatory issues, who is Dr. Joana Riaño. She is the head of clinical trials unit in our hospital. And we also have an advisory committee, including key leaders in oncology, surgery, and hepatology. Each participating center has a principal investigator, and we have, as you will see in the next slides, multiple centers on board. So we are very happy to say that since 2017 that the data capture was initiated, we have more than 5,000 patients included in the registry from 46 international institutions and 18 different countries. From Europe, we have 40 centers involved from 12 countries. Most of the patients were included from Spain, UK, Germany, Italy, and the Netherlands, but also we have from Austria, Belgium, France, Lithuania, Norway, Poland, and Romania. From Latin America, we have 6 centers from 5 different countries, from Argentina, Brazil, Chile, Ecuador, and Peru. And we are very happy to say that we have a new center from India that has included more than 400 cases from India. And we are also working in the involvement of centers in China, South Korea, and Japan. So currently there are 20 institutions that are interested to participate, and we are working in all the paperwork. So as a general overview of the registry, regarding the cholangiocarcinoma subtypes, most of the cases are intrahepatic cholangiocarcinomas, around 45%, followed by perihilar tumors, 33%, and distal cholangiocarcinomas, around 16%. It is important to highlight that we also have mixed ACC cholangiocarcinomas, more than 100 cases that we want to evaluate in detail in the next future. The median age at diagnosis is 66 years, but this age at diagnosis is heterogeneous. We have patients from between 20 and 99 years old. Regarding the physical fitness as diagnosis, most of the patients show a good physical fitness with a COG performance status values between 0 and 1 in more than 80% of the cases. Regarding the demographics, there is a slight higher preponderance of male versus female, 57 versus 43%. Regarding the ethnicity, most of the cases, around 60%, are Caucasian, but we also have Hispanic, 2.3%, Africans, 1.1%, and also from Asia, 8.6%. Regarding metabolic conditions, obesity is presented in 15% of cases and diabetes in 18.5%. As you know, these are two important factors of the metabolic syndrome and also from non-alcoholic fatty liver disease. Arterial hypertension is present in around 30% of cases and hypercholesterolemia in 10%. Regarding the exposure to drugs, toxins, and chemicals, smoking was reported in about 23% of cases and alcohol abuse in 14% of cases. Regarding inflammatory diseases that increase the risk of cholangiocarcinoma development, PSC is present in 3.4% of the cases, PBC in 1.3%, inflammatory bowel disease in 2.6%, cholecystitis in 2%, biliary tract stones 3.6%, and liver cirrhosis in 5.4%. Regarding infectious agents, we don't have cases of infection with Orpistorchis viverrini or Clonorchis sinensis. As you know, these are endemic parasites from certain regions of Southeast Asia and responsible, at least in part, of the high incidence of this cancer in those regions. However, since we are willing to involve centers in China and South Korea and other countries in Asia, we envision to have cases with these infected parasites in the next months. Regarding Helicobacter pylori, it was reported in 0.4% of cases, hepatitis C viral infection in 2.5%, hepatitis B viral infection in 3.1%, and HIV in 0.3%. Regarding diagnosis, most of the cases are diagnosed by the evaluation of the tumor, by biopsy, cytology, or in the tumor resection, as you can see in 70% of cases, and 30% just had a radiological imaging diagnosis. Regarding treatment, 47% were unresectable cases and underwent palliative treatment, and 47% of cases had tumor resection. Regarding the success of the surgery, 70% of cases have a R0 tumor resection, so without margins of disease. 27% has R1 tumor resection, so with microscopic margins of disease, and the median recurrent-free survival was 11.5 months. Regarding systemic therapy, most of the cases received chemotherapy, 99%, and 0.5% received immunotherapy, and 0.7% targeted therapies. As you know, immunotherapy and targeted therapies were approved in the last months, and so we envision to have new cases receiving these treatments in the next upcoming months. Regarding chemotherapy, Genthis was the most common therapeutic regime in 70% of the cases, and the median progression-free survival was 6 months. In general, in the whole registry, the median overall survival, including cases for surgery, palliative chemotherapy, and best supportive care, was 10.4 months. 66% of the patients were deceased to now, and 34% are under follow-up or lost. Regarding the cause of death, 91% of cases were related to the cholangiocarcinoma itself. So we are now putting a lot of effort to include the tumor molecular profiling, also patients receiving targeted therapies, immunotherapies, and also combination therapies, chemotherapy plus immunotherapy. As milestones of the registry, I want to highlight this manuscript published last year in Journal of Hepatology. This was selected as a cover picture of the journal in the month of the publication, and one of the most important manuscripts published in 2022 in the journal by the editor choice. Here we presented an overview of the natural course of cholangiocarcinoma in European countries, providing information on baseline characteristics, median age at diagnosis, male to female preponderance, as well as the risk factors. We also provide information on tumor features and biomarkers. For instance, we show that CA19-9 is not a good biomarker for diagnosis, particularly in early stages of disease. However, once this biomarker is elevated at diagnosis, this is associated with a high risk of presenting disseminated disease. We also provided valuable information on the management with median overall survival in large number of cases, receiving tumor resection, active palliative treatment, or best supportive care. And also, after multivariate analysis, we provide information of 3 independent prognostic factors, which are the ECOG performance status, the disease stage, and the serum levels of CA19-9. Here you can see another publication in hepatology in 2021. Here we put our attention in those intrahepatic cholangiocarcinomas with liver dissemination of the disease, which are currently staged as a local disease. However, we found that these patients have a similar prognosis than patients with a metastatic disease, indicating that these patients should be staged as M1A. These data are now under evaluation by the WHO for a potential change in the staging system. Here I show you another study where we evaluated the impact of lymph node invasion and the resection margin status, showing that in the presence of positive regional lymph node, the resection margin status does not determine the overall survival or the recurrent-free survival in patients with perihilar cholangiocarcinoma. I show you another study published last year also, particularly here only including patients from Brazil, showing that the metabolic disorders, in this case diabetes, overweight, and obesity, are frequent among patients with cholangiocarcinoma and might be associated with better prognosis under resection compared to cholangiocarcinomas not associated with metabolic disorders. So we have ongoing 7 collaborative studies on different aspects of the disease, and we are going to start new studies in the next month. So finally, I want to thank all the people and centers involved in the World Cholangiocarcinoma Registry, as well as our international sponsors and all of our partners and collaborators. Thank you very much for your attention, and very well regards to all of you.